and we're going to go ahead and begin our webinar. First of all, I want to thank you for joining Resolve today. We have more than 200 people registered to watch this webinar from their own computers, and we also have a group of people here live in Washington, D.C. I want to thank you and welcome you to this very important webinar. I want to start by thanking the Biotechnology Industry Organization, or BIO, and their staff for allowing us to use their beautiful office space here in Washington, D.C. to host our webinar. They've just been fantastic to work with, and I want to thank BIO. I also want to thank Merck for providing the grant that made today's presentation possible. I want to thank the Resolve Board of Directors for supporting this idea and encouraging Resolve to be a leader on this topic. I want to thank our grassroots volunteers across the country who every day get involved in our federal and state advocacy efforts, making the voice of the infertility community heard. They are making a real difference. And don't forget that all professionals in the infertility community are invited to be part of our advocacy efforts, as your voices are needed too. And lastly, I want to thank the incredible Resolve staff for fulfilling our mission each and every day. Today, you will hear from Kelly Brantley of Avalere Health. I first met Kelly in 2010, right after the Patient Protection and Affordable Care Act was passed by Congress. I have heard Kelly speak on countless occasions, and I am the wiser for her rich knowledge and insight into the ACA and its implementation. Avalere Health, in my opinion, is the top health policy firm when it comes to the ACA. I'm sure they would think they're the top health policy firm on all topics, but in particular the ACA. They work every day to solve the challenges of the healthcare system. We are privileged today to have their expertise on this important topic. Following Kelly's presentation, we will take your questions and do our best to answer as many as possible. We've listed instructions on how to ask a question. If you look up in the top right corner of your screen, you'll see a very small orange box with a white arrow. If you click on that box, you will see a chat box open up about halfway down your screen on the right, and that is where you will post a question. Please do not use the raise hand feature. Use the chat box feature to ask your question. Following today's webinar, Resolve will pull a full list of all the questions that were posed, and we will provide answers to all of them in the next several days, even if we do not get a chance to answer them here today. And remember, we are recording today's webinar. We will be posting it on Resolve's website, and everyone who signed up for the webinar today will receive an email from Resolve with a link to the webinar, and we will then be promoting it throughout Resolve's various channels over the coming weeks. After the Q&A with Kelly, I will share some insight from Resolve. I will share what a few states are already doing to respond to this issue, and we'll take your questions and begin a dialogue on our next steps. I realize your time is valuable, and we appreciate your interest in this important topic. With that, I will turn it over to Kelly Brantley from Avalere Health. To find the green button that I needed to press. Good afternoon, everyone. I'm very happy to be here. As Barb said, my name is Kelly Brantley. I'm a senior manager at Avalere Health. And Barb, I have to say that was the kindest introduction I've ever had. It was wonderful. So thank you so much. It was incredibly wonderful. And I feel very welcome to be here. So I'm happy to be here today. We're going to talk about something that is near and dear to my heart, infertility treatment and infertility mandates, and how it applies to the ACA and how the ACA sort of impacts infertility mandates, and really what we know and what we don't know, because there's still a lot that we don't know as well. So I want to be upfront about that as well. And for those of you who don't know about Avalere, we are a DC-based firm. We have about 200 staff people operating here and all over the country. We are an advisory services firm. There we go.
So we're an advisory services firm, which is essentially a consulting firm, and we offer policy expertise to a variety of stakeholders in the healthcare marketplace. So anywhere from health plans and providers to the advocacy community and life sciences companies as well. So I'm happy to be here. We're going to talk about some exciting things today, and here are the contents of the presentation for this afternoon. First, we're going to talk a little bit about the ACA, what we know, what we don't know, which is ridiculous that in 2014 we still don't know things, but there are plenty of things we still don't know. So we're going to level set there and just get everybody grounded in the facts. We're going to move and talk a little bit about what coverage looks like according to the ACA. There were requirements about what needed to be covered and how it needed to be covered, and that's a concept known as essential health benefits. Then we're going to move into a discussion about state mandates and specifically infertility mandates. And then finally looking at what does it look like actually in real plans. So it's all very fine and well to understand the policy behind everything, but the next step is to look at what are people looking at when they're shopping for plans. And then finally talking a little bit about implications and next steps for what folks like you can do. Okay, so first we're going to start again with sort of laying a little bit of groundwork about the ACA. And so there was 3 major goals of health reform. The idea behind health reform, the biggest idea behind health reform was to expand coverage to a broader swath of people, to lower the rates of uninsurance and to increase opportunities for people to access actual health coverage, making it more accessible and affordable. So through a system of exchanges, which are marketplaces for health insurance, as well as subsidies to allow people to afford it more easily if they have limited income, expanding Medicaid, which we'll talk just very briefly about in a moment. The second major goal of health reform is to think about delivery and payment system reform, because the idea behind it was not to continue the same cost curve that we have experienced, the growth of over the past, 100 years or so. It's been really growing exponentially, and the idea behind delivery and payment system reform is to really change incentives so that the system works more efficiently and pays for quality over volume. Finally, the ACA looks for ways to establish good, sustainable funding for all of these programs so that while we are expanding coverage, it's still not going to add to the deficit, at least as envisioned and according to the law. And so there were sustainable funding mechanisms envisioned in place in the ACA that we're not going to talk about today. But these are the 3 major goals, and really they all sort of work together to sort of comprehensively change the way we're thinking about healthcare in this country. So one of the things to keep in mind is that the roles of health insurance for people who has what types of health insurance does change substantially between 2013 and 2017. And this is, keep in mind, these were projections that were created prior to the healthcare.gov rollout, which some might agree that did not maybe go as envisioned, or did not go as smoothly as envisioned. And so should keep that in mind when we're thinking about exchange enrollment numbers and estimates on this slide. But really, there's a lot that stays the same between 2013 and 2017, 5 years down the road. Medicare grows at the rate it's been growing. Nothing really changes there in terms of numbers of enrolled individuals. The employer-sponsored market is still fairly stable and is, growing pretty slowly, but still on the same sort of projection that it had been. What else is here? The uninsured. The thing to look at right here, the big key here is uninsured moves from 49 million individuals down to 23 million individuals in 2017. Still a lot of people who are uninsured, but that is a major win for the ACA. The idea behind it is that there's way too many uninsured folks and that the rest of us all bear the cost of providing care to the uninsured because they are not outside of receipt of health care services. They're receiving services. They're just receiving it in the emergency room or other types of places that is actually costing the rest of us who have health insurance. It costs through our premiums and through higher payments to hospitals and doctors to make up for those costs. The line to look at as well is the Medicaid line, and this modeling does account for those states that opted to expand Medicaid. It was an option that was decided by the Supreme Court a few summers ago, that the Medicaid expansion that seemed to be required by the Affordable Care Act, in fact, became an option based on the Supreme Court's decision. And so 24 states decided over the past year not to opt in to Medicaid, not to opt into Medicaid expansion, and therefore those numbers, that 59 million by 2017, is not necessarily as high as it It could be, or maybe even will be, because this projects forward the same decision that those states made based on the end of 2013. And so should more states opt in, which they are, in my opinion, likely to do moving forward because there is so much money involved behind it, you could very well see that number 59 million be substantially higher. And that's going to pull from both that uninsured line and also the exchange line, which is the next thing we're going to talk about. So exchanges are a new marketplace for people to purchase health insurance. It's not for all people to purchase health insurance. It's for individuals and small businesses. So those folks who have either getting coverage through their small business, their employer, or providing coverage as a small employer, or they're people who have been shopping on their own in the past and were either able to get an individual health insurance plan because they were healthy enough to be able to access one, or lucky enough to live in a state that required plans to provide coverage even for folks with pre-existing conditions. But moving forward, that change in the law about pre-existing conditions is changing everything for folks in the individual market. So now anyone can qualify for an individual health insurance plan through the exchange, in theory, and purchase a plan and not be rated based on their previous health status. So that is something to keep in mind. Again, the exchanges are not for everyone, but they are there as an option for folks who have been on the individual market as well as those in small businesses. And then, not to talk too much tech about what is an exchange, but just really to lay a little bit more groundwork. States were given the opportunity to create their own exchanges, and really the ACA envisioned this idea where states would all be creating their own exchanges. And only in, there was a sort of side little provision in the ACA that indicated that if a state should not set up an exchange, that the federal government would go in and set one up for them. But it turns out that a lot of states took the federal government up on that, and a lot of states said they're either not willing to or not able to, or just they don't have the time or interest, frankly, in setting up their own exchange. So this map shows you a little bit about how everything played out, at least for the year 2014, with 15 states and DC operating their own state exchange. Another 15 or so in the middle sharing those tasks and things that they have to do to set up an exchange with the federal government. That's either through a formal partnership or through a less formal partnership known as the plan management function of the federally facilitated exchange. And you'll see the bottommost line here with the gray states. Those are the federally facilitated exchanges where the federal government is operating an exchange in those states. Now, they're still sort of state-based exchanges in that they only exist in the state. It's not that the federal government took them all under their one big umbrella and it's a single big entity. The states, even in those federally facilitated exchange states, are still in charge of doing a lot of things related to insurance market regulation that they have done in the past. They help plans set rates. They are in charge of network adequacy. They are in charge of accreditation and making sure that plans that are operating in their states are accredited the way they are supposed to. So really state that nothing changes in terms of insurance market regulation. States are still in charge of that, and even in those gray states where the federal government is running the exchange, those states still have a very large role to play. I will pause, though, because this is the end of the first section, and see if there's any questions that are queued up. Fantastic. All right, so let's talk a little bit about what the ACA says about what coverage is supposed to look like in the exchanges, and this is the concept known as essential health benefits. And we're going to talk on this first slide about what the ACA says, which, as you see, the fact that you can fit it on a single slide gives you some indication that the ACA did not say much about what is supposed to actually be covered by these new marketplace plans or exchange plans. So the ACA said there should be 10 categories of essential health benefits covered by plans. They did not say what services fall into each of those 10 buckets. Those 10 buckets, in case you can't see on the slide, include ambulatory patient services, emergency services, hospitalization, prescription drugs, laboratory services, preventive and wellness services, chronic disease management, these sorts of things. They're just sort of general guidelines. Nothing is very clinical here. You don't see, it's not a list of services. It's a list of buckets or a list of categories. And so we had all eagerly, anxiously awaited a regulation that further defines that. And we're going to talk more about how that didn't exactly go as everybody thought it would in terms of defining what are the benefits covered under each one of these buckets. But as of right now, we're talking about the ACA. There's 10 buckets. That's all we know so far. It applies to individual and small group plans. One thing to keep in mind is that it applies to individual and small group plans regardless of being in the exchange. So even individual and small group plans outside of the exchange must meet essential health benefit requirements. The ACA also established something known as an out-of-pocket maximum. And what this means is that essentially people are not going to be bankrupted by the costs of health care anymore. If somebody is enrolled in an exchange plan, their out-of-pocket expenses are capped at $6,350 annually for an individual, or double that, $12,700 for a family. And these numbers are for 2014, and they'll be indexed in future years. But that's something to keep in mind, that for covered services that are received in network, a person cannot pay more than $6,350 in a single year, which still could be a lot of money for a lot of people, but it's a lot less than millions of dollars that we were potentially seeing in previous years and before the ACA went into effect. And this out-of-pocket maximum goes into effect. It began January 1st of this year. The other thing that the ACA said was that plans, you need to have some way to compare plans. You need to have some way to decide what plans are sort of on the same level as each other. They wanted a sort of grouping system so that you can make an apples-to-apples comparison, that there should be different levels of generosity, that not everybody needs like a Cadillac plan, not everybody needs the fanciest plan available. And so they established 4 different levels of plan, from bronze up to platinum. Bronze is the least expensive premium plan, but has the highest out-of-pocket cost. So you might pay a little per month to be enrolled in a bronze plan, but when you go to the doctor or the hospital or get a prescription drug, your out-of-pocket costs will be higher. In fact, your out-of-pocket costs will be 40% on average for those services. The way this works, and we're not going to go into this topic of actuarial value, but the idea behind this, the measure of generosity, is this concept known as actuarial value, where it's just a measure of how much of the expenses of being enrolled in that plan for an average person are paid for by the plan. So that's what the 60% means. In a bronze plan, 60% of the costs of being in that plan are paid for by the plan, and the person who is enrolled in it, on average, is going to be responsible for 40% of those costs. So if we work our way up to silver plans, it's a 70% actuarial value, gold is 80, and platinum is 90. And so you might imagine that platinum plans have the highest premiums per month to enroll in, but the lowest out-of-pocket costs, because that person who is enrolled in a platinum plan is only responsible for, on average, 10% of the cost of being enrolled in that plan. So that's something to keep in mind when people are shopping for exchange plans and they see there's a whole heck of a lot of silver plans. They know that on average they're going to get the same bang for their buck in a silver plan, whether it's from issuer A or issuer B. And so what we saw in regulation, and this is something I alluded to a little bit earlier, was not so much a list of benefits that came under each of the 10 buckets of services. We saw the federal government deferring to states, and the federal government said, states, I am giving you the option to select something known as a benchmark benefit plan. And it will be one of these 10 options. So there's 10 options that fall into 4 categories. So the 3 largest state small group plans, the 3 largest state employee plans, the 3 largest federal employee plans, and the largest HMO plan in the state. And so that's 10 types of plans in 4 buckets, and states were given a certain amount of time to select a benchmark benefit plan. Okay, thanks. Will do. Sorry. Thank you. So there's 10 plans that fall into 4 buckets. And states were given the option to choose, and there was a deadline at the end of 2012, and states that didn't choose had a plan selected for them, and that was the largest small group plan in the state. And really what ended up happening is that about half of states didn't actually pick a plan, which kind of goes along with the other things that we've seen here, that there are states that are very engaged in this process and states that don't really want to have a lot to do with the process. And so those states that selected the plan, the vast majority of them still selected the small group plan, a small group plan in their state. So in fact, 45 states have a small group plan as the benchmark. And what does that mean, this benchmark? The idea behind it is that this benchmark, the set of services covered by the benchmark, would then be classified into those 10 buckets of essential health benefits, and that is considered what the essential health benefits look like for that state. So whatever Wyoming's benchmark looks like, that specific small group plan, I think, in Wyoming, that would be what benefits would look like for exchange plans in that state moving forward. And it really was, the idea behind this, I think the federal government really wanted states to be engaged and really felt that giving them all these opportunities to weigh in was a way to allow states to be part of the process, and the fact that some states just didn't participate was just, I think it was not what the federal government had envisioned, but I think the federal government really felt like its hands were tied, that they wanted states to be in part of the process, that states know about the insurance market that's already operating in their state, and they wanted benefits to really be comfortable to folks who are already in those states and who were used to having plans that looked like what was already available in their state. And so that's really, I think that was the thinking behind this, the way this regulation was written. Whether it worked and whether it will continue to work this way remains to be seen. But it allowed a lot of good things that we're going to talk about in a moment. But there's limitations in this process as well. There are limitations in having a different plan, a different EHB really in every state. And so this is what states actually either selected or had selected for them. 19 states in DC selected small group plans, as we said. 26 states defaulted. 2 states picked a state employee health benefit plan. Those are out west, Utah and Arizona. And 3 states selected an HMO plan, Michigan, North Dakota, and Connecticut. All the other states that actually made a selection selected small group plans. And again, 26 states did not make a selection, so just about half of states. And those defaulted to the largest small group plan in that state. And so what does this mean for infertility treatment and infertility services? And I think it's not incredibly clearly defined, and I think everybody understands that there's no set definition of infertility treatment. It's not a single thing. You can't just say it is this one thing, or it is even this set of 5 things. It means something different to every plan. It means something different to every person in need of it. It's really every doctor who is practicing. The set of treatments and services that really fall into this category really even fall across the essential health benefit benchmark categories as well. So would you put them in prescription drugs? Sometimes. Would you put them in ambulatory care services? Potentially. Maternity benefits? Maybe. So really it could fall into a variety of buckets, and how those services got bucketed or would get bucketed by a plan. There's no real guidance on how to do that. The federal government didn't micromanage that process. They just said, here's the 10 buckets. There's your benchmark plan. Go. And so what it could mean is a variety of things. I mean, what is covered by a plan could be any of these things. It could include IVF. It could not include IVF. It could include any of the services or treatments listed here. It could include, prescription medications that may or may not fall under a pharmacy benefit or medical benefit, depending on if it's physician administered or if it's self-administered, like an oral med. All of these things are possibilities, and since there's no comprehensive, agreed-upon definition of what all constitutes infertility treatment, it really does leave a lot of variability to plans and to states and to benchmark plans. And so there's a lot of uncertainty even today, even when we know that there's a mandate, even when we know that the benchmark benefit plan that was picked actually meets the mandate, there's still a lot of uncertainty. And so first we're going to talk a little bit about what the guidance and regulation has said about drugs, because we sort of have to bucket things into medical services versus drugs. And so first we'll talk about drugs and what HHS said. And HHS, the Department of Health and Human Services, which is the parent organization of the Centers for Medicare and Medicaid Services, just in case anybody is, for those of you who don't live in DC and live and breathe this stuff, I'm trying to do my best here to demystify the acronyms. So what CMS said in this regulation on essential health benefits is that plans would have to cover the same number of prescription drugs in every single USP category and class that is covered by the essential health benefit benchmark. So if a plan covers 3 anti-diabetic agents in the class, then plans in that state must cover at least 3 anti-diabetic agents in that class. The classes are defined by the United States USP, which is the United States Pharmacopoeia. There are model guidelines that are established for the Part D program, so that's the Medicare program. You might imagine, what does Medicare have to do with exchanges? And not a lot. The answer is not a whole heck of a lot, but it is one system that was in place that divided almost the breadth of all prescription drugs into clean categories and classes that would structure, it would give plans a way to structure a formulary. Oddly, though, there is no USP category or class that includes infertility medicines. So this makes it really tricky, and also means that if a benchmark benefit plan covers an infertility medication, regardless of if it's required, there's no way for states or insurance commissioners or exchanges or the federal government, whoever is the entity responsible in that state for reviewing formularies, there's no gold standard for that specific medication. So whether a plan covers it or not is not necessarily tested. So I'll just let that sink in a little bit. This is not great. There are other conditions and other treatments that are in this sort of same situation. USP is not the end-all be-all. It doesn't cover a lot of different categories. One might imagine categories, sort of informal word categories of treatments. And so it isn't necessarily the best way to classify a set of drugs. But it is the one that the federal government selected, and so it is the one that we are using, at least in 2014 and in 2015. And so this drug count methodology, this protection that requires plans to cover that same number of meds that are covered by the benchmark benefit plan, doesn't protect infertility meds. That's at least the outpatient, the oral meds, those self-administered medications. And so what this means for states with mandates is that there's still some up in the air about this. And when a state has a mandate to cover specific medications, whether it's by name or by classification system, then it is up to the state, whoever has been reviewing whether the plan met the benchmark, or met the mandate, excuse me, in that state, then that entity is still responsible for making sure that that review happens and that the plan meets the mandate. So in those states that have a mandate for individual and large group plans, those individual plans that are in the exchange must be reviewed in the same sort of way, whether they're reviewed or not, and that's the way that nothing there has changed. The federal government doesn't come in and review that, exchange plans meet the mandate when they're required to. That's completely a state-run process, and it remains a state-run process. And then I think we talked a little bit about what this means for pharmacy benefit. What it means for medical benefit is also that there are no USP classes or categories for medical benefit products either. So in the infertility space, there's a good bit of medications that are covered, that are physician administered, that would be covered under the medical benefit, and how those products are covered, if they are covered, how much they cost, whether there's a formulary or not. None of that has a protection in the same way that the outpatient benefit, or the outpatient drug benefit works. There's no counting methodology for those drugs either. I'm always the voice of doom and gloom. I go everywhere and I give doom and gloom. But I will pause for questions just to see if anyone has anything to ask about essential health benefits.
So we have a question. I hear on the news all the time about the problems with the federal government health exchange website. I live in Maryland. Does that mean I would never use the federal government website, or do I get to pick between going to the government exchange or my local state exchange?
That's a great question. And so living in Maryland, Maryland is a state-based exchange. It has its own exchange. And so if a person would go to healthcare.gov looking for plans in Maryland, that healthcare.gov sends that individual to the Maryland exchange. So there's a hot link that goes directly to the Maryland exchange. And that person would not be able to shop at healthcare.gov because Maryland is running its own exchange and operates all of that process.
Kelly, I have another question. The slides that you just presented were specifically about the essential health benefits. And could you just pause for a moment and remind everybody who is covered under the essential health benefits? When you first started your presentation, you had a bar graph from 2013 to 2017 that showed the number of people covered by Medicare, by employer plans, by state exchanges, uninsured, the new exchanges, and Medicaid. Again, could you just remind us who is covered, those essential health benefits, who do they apply to in the U.S.?
Sure, that's a great question too. Essential health benefits apply to all individual and small group plans in the country, whether they are in an exchange or outside of an exchange. They also apply to the Medicaid expansion population, sort of, which we won't get into the nitty-gritty of that, but they sort of apply to the Medicaid expansion population. And what the Medicaid expansion population is that group of individuals who are above the Medicaid eligibility levels for previous years, but below 138% of the federal poverty level, which is where the expansion afforded by the ACA allows states to go up to.
Okay, I have another question. Regarding the pharmacy formulary, if infertility drugs are placed on the formulary, does it mean that lifetime maximums cannot be applied in the same way they can for medical expenses?
That's a great question. So there's a couple of things happening there. So lifetime maximums, annual and lifetime limits are something a little bit different than the out-of-pocket maximum, and I probably should have mentioned that when we were on that first EHV slide. So beginning in 2014, or by now that it's 2014, plans are no longer eligible or able to have annual or lifetime limits on services. So they cannot have a dollar limit. So they can't say, we will cover up to $500 of rehabilitation services or occupational therapy. They can say, we'll give you 10 occupational therapist visits. So a numerical limit is okay. A dollar limit is not okay. And that is also the same as lifetime limits. You cannot say, no plan can say, you have maxed out your policy. You cannot spend more than, say, $5 million in your lifetime on benefits. We will no longer pay for you. That was something that had been in the market for forever, especially in the individual market. There were lifetime limits like that. There's no such thing anymore. Plans are not allowed to have those annual or lifetime limits, and that's the limits on what they will pay. The out-of-pocket maximum is what the person who is enrolled in the plan cannot pay more than, and that $6,350 is based on covered essential health benefit services that are in network. Go ahead. So I will, though, reiterate that one point, that so it's covered essential health benefits that are received in network. And so if a benefit is covered by the benchmark plan and then also covered by the plan in the state, that is considered essential, an essential health benefit. So if the benchmark benefit covers an infertility oral medication, for example, and the plan that a person enrolls in also covers that medication or a similar medication, that's considered an essential health benefit, and there is a $6,350 limit. So anything a person receives in network, so all of their doctor visits that they receive in network, all of their specialist visits in network, hospitalizations, prescription drugs that are on the formulary, all of the covered care that a person would typically receive, all of that person's out-of-pocket expenses cannot exceed $6,350. So that could be made up of the deductible and then some co-payments and maybe a co-insurance. Depending on how the plan is structured, those out-of-pocket benefits, how much that person pays out-of-pocket, all sort of gets added into this tally sheet. And once that person hits $6,350, it's not that they're cut off. What it means is that all covered services after that point are received free of charge to the individual. There's no out-of-pocket cost for it. The plan pays the full cost of those services. So if a person, let's imagine a person gets hit by a bus and hospitalized on day one and maxes out their out-of-pocket maximum, they have paid $6,350 to the hospital and the ambulance service, or however you want to divide that up. And all through the rest of the year, they have recurrent hospital visits and maybe some x-rays, and then they've got some rehab. All of those covered services are received free of charge, no out-of-pocket cost for that individual.
So Kelly, we have a question from the room here, so we're going to repeat your question. So go ahead and ask it. Can you repeat?
I will repeat the question. The question is whether the out-of-pocket maximum applies to all plans or if it's just a small group and individual market, and that's an excellent question. It applies to all plans, so even large group plans. I do believe it does not apply to grandfathered plans, but I may need to double check on that. Those of us who are employed by large employers, if our plans are not grandfathered, that out-of-pocket maximum is in place for us too. So this benefit, this out-of-pocket maximum, is a new benefit for many, many more people than just the essential health benefits and other exchange plans.
I still see lifetime max on infertility benefits. Are insurance companies still allowed to limit treatment?
That's a great question, and I think it has to do with whether the infertility benefit is considered an essential health benefit. And if it is, that's only in a state that has a mandate, and how that works is all very different. It also could be that there are lifetime, are we talking dollar limits? Are we talking limited services? Limited services are okay, like numbers of visits or number of IVF rounds. Those kinds of things are fine. They are permitted by the ACA. Limits on dollar amounts are not permitted by the ACA on any service.
And just to follow up, you will see many plans that will have a lifetime dollar limit of, let's say, $5,000, $10,000, et cetera, for infertility treatment. And that might be from a large employer coverage plan. So can you explain, are those still in place?
That's a great question. And I don't think they're permitted. I really don't. I think dollar limits on any service is not permitted moving forward. And I'm like racking my brain now because maybe I'm thinking incorrectly, and maybe it is just essential health benefits. But I can double check on that. You've made me question my my brain on this.
Okay, one more question. There are some questions that might go unanswered, and as a reminder, we will post all questions submitted today and answer them to the best of our ability once the presentation is over, and that will be on resolve.org. So the final question for this section is just kind of maybe summarizing what you're talking about with fertility meds. Bottom line, are fertility meds not going to be covered at all?
It depends on the state. The answer is it depends. It's like the story of my life as well. I go places, I give doom and gloom, and then my answer is it depends on almost every single question. It depends on the state that a person is in. If a person is in a state that has a mandate and the state selected a benchmark benefit plan that covers the same, that meets the mandate, then that mandated benefit, and we're going to talk about this in the next section, those services required by the mandate that are covered by the benchmark plan are considered essential health benefits, and therefore are required to be covered by individual and small group plans, both inside and outside of the exchange. But we will talk more about that, which is actually a great way to tee up the next section, which we're going to talk about how state mandates are treated under the ACA and what the ACA said, and then how regulation sort of contradicted it and allowed a little bit of wiggle room for some states. And so first we're going to talk about what the ACA said, and it was kind of a puzzling provision that was inserted here that talks about state mandates, and it generally defers to states in order to determine what mandates are in that state. And then it says that the state must assume the cost. Now what this means is that for benefits that are required in a state, the mandated benefits that exceed what is known as essential health benefits, and at this time, remember it's the ACA, all they said was the 10 categories of services, they hadn't defined it yet. If a state mandates benefits that are in excess of essential health benefits, then the state must, quote unquote, assume the cost of those excess benefits. So not if it's considered an essential health benefit in full would the state have to assume the cost. It's only if those mandated benefits are in excess of essential health benefits would that state have to be responsible for that cost. Pause for a second to say that the ACA also didn't say what that meant. They didn't say who makes payments. They didn't, I mean, except for the state. They didn't say how. They didn't say how it would be determined that a benefit was in excess of essential health benefits. And so it was a big mystery for a very long time. Lots of states were really freaking out about the mandates that they had passed at that point. They were worried that they were going to be on the hook for every single mandate that they had passed. And as advocates know, it's one of the big things that advocates have done and that patient groups have really pushed for is mandated benefits, because it really does protect very vulnerable populations, and it's a way to get more people access to better care and to force issuers and insurance companies to pay for services that really are needed by the community. But then when states realized that their necks were on the line, their wallets were on the line for potentially paying for these, there was a very large gap by many, many states. And so what the federal government decided, and we're going to talk a little bit about this on the next slide, and at least in more detail, is that remember how we talked about the state getting the option to select a benchmark benefit plan, that if the state picked a benchmark benefit plan that covered the mandate, so if the mandated benefits were covered by the benchmark benefit plan, then those benefits are considered essential health benefits automatically. They meet the definition of essential health benefits. They are not in excess of essential health benefits. And that's even the same for something like formularies. So for if the benchmark benefit plan covered, we talked about the 3 anti-diabetic agents and, whatever. If a plan that has to meet that benchmark covered 10 anti-diabetic agents, the state is not responsible for paying for those extra 7, slow math today, the extra 7 drugs. The state is only required to pay for a mandate that's in excess. So if the state said you must cover 10 anti-diabetic agents in this class, then absolutely those extra would be paid for by the state, whatever that means. Does that make sense? I'll pause for a second just to make sure that makes sense. It is tricky. And I mean, what the federal government did by writing this regulation this way is give states an option to pick a benchmark benefit plan that covered all of their mandates and not to have to pay for them at all, not to be on the hook for them, not to assume the cost or make payments or figure out what any of that means. Oddly, and we're going to talk about this in a moment, there are 2 states that did not actually pick, that have mandates, that did not, or some sort of mandate, and did not pick benchmark benefit plans that met their mandate. So what that means for Maryland and Arkansas sort of remains to be seen, and we will talk about that more in a moment. And so let's talk about what it means for infertility services. And so if there is an applicable state mandate requiring some level of infertility treatment, and if that mandate was enacted prior to January 1st, 2012, then that infertility treatment, that mandate, plans have to meet that mandate. If the benchmark benefit plan that is selected by the state covers those services and it meets the obligations of the mandate, then those services, those infertility treatments mandated, are considered essential health benefits. And so that means that individual and small group plans, both in and outside of the exchange, must meet that mandate. But let's imagine a scenario, and I think there's a couple of scenarios like this, where the mandate is not for all individual and small group plans in the state. I think that Maryland is one where it's individual plans and large group plans, but not small group plans. So it doesn't work the same for them, because the small group plan, even though it's considered an essential health benefit, we're talking just about Maryland right now, small group plans in the exchange are required to meet essential health benefits, but they can also substitute benefits. That's one of the things that's allowed with essential health benefits, and this is getting into the nitty-gritty of policy here. Because they're not mandated to cover these benefits, they're not subject to that same mandate. And so those small group plans in Maryland, even if they have to meet essential health benefits, do not have to meet the mandate in that state because they're not mandated, even though it's essential health benefits. Was that enough caveats? Okay. And so also what this means, mandates and how mandates are treated, and the fact that it will count, mandates count if they're in a benchmark benefit plan that's selected by the state. They count as essential health benefits. This is the policy for 2014 and 2015 only. CMS has said that it will revisit this policy for plan year 2016 and beyond. It's very possible they'll change their mind about how they did this. One might imagine, I've been theorizing that they are going to keep this policy in place for 2016 at the very least. At this point, and we'll probably talk more about this momentarily, but the regulation is going to have to come out about essential health benefits later this year. At that point, how much data is CMS going to have on how well this works? Not much. they're going to have a few months of data just in those federally facilitated exchanges. Maybe they'll have some data from states. Okay, great. But there's not a lot of data, maybe 6 months of data, and actually probably less. I mean, especially with the rollout and the few enrollees, and the fact that those who are enrolling now are not necessarily indicative of the vast majority of enrollees that one might expect over the course of exchange plans. So it's probably not wise even for CMS to change their approach with unknown data, limited data, not a lot of time elapsed, and to see how people are actually spending their time and effort enrolled in this plan. Like, are they receiving the benefits, and are they navigating the plan appropriately? I mean, all of these questions will remain even in August of this year, and that's where they're going to have to write the next essential health benefit rule if they're not already writing it. And so I suspect that at least for 2016, we're going to see the same sort of policy approach, whether states are given the option to pick a new benchmark benefit plan or not. That is a question that remains. But I suspect that at least for 2016, we are all set with the way mandates are treated right now. Don't quote me on that. Okay, so here's a map. And what this shows you, and there's a lot of caveats at the bottom that I will draw your attention to, is that there's 9 states that have mandates for some level of infertility treatment and that have mandates that are recognized by the federal government. And so what states had to do a few years ago was submit to the federal government a list of all their mandates. Now, some mandates counted, and I'm putting that in quotes for those of you on the phone. Some mandates counted. Benefit mandates counted. So if a mandate required a set of benefits or a specific benefit or types of benefits or scope of benefits, all those sorts of things counted as a mandate. If the mandate said you have to pay for a specialist and a general practitioner the same amount for these services, that's not a mandate. That has to do with reimbursement rates and costs and has nothing to do with a mandate per this requirement here. And so that's the definition of mandate when it comes to federally defined mandates for the purpose of essential health benefits. So those 9 states outlined in orange here, the federal government recognizes as having mandates that cover some sort of infertility treatment. And keep in mind that the range of what that means varies substantially. In some states, it could be as little as, we will ensure that you get diagnosed as having an infertility issue, as opposed to actually treating the issue. So it really does vary. Then there's, on the other end, where pretty much all things infertility could be covered by a plan. An additional 13 states selected a benchmark benefit plan that covers some infertility treatment. Again, what that actually means varies substantially from plan to plan and from state to state. When the benchmark benefit, some benchmark benefit maybe in Texas said exactly that we will ensure that you get diagnosed with an issue of infertility as opposed to treating it. That could very well be what's here in these 13 states here. There is some level of infertility treatment or services that are covered by the benchmark benefit. What this means, this benchmark benefit, we'll reiterate this. So services covered by the benchmark are considered essential health benefits and are required to be covered or substituted out in an actuarially equivalent way by plans, by small group and individual plans, either in or outside of that state's exchange. So even in Texas, if the benchmark benefit requires infertility treatment, a plan, a small group or individual market plan in that state must at least account for how it substituted those benefits out. So it's possible they will substitute them out. It's also possible that they will cover them, and that remains to be seen. And we're going to talk a little bit more about how one would determine this in the next section. And this slide is just really to reiterate the uncertainty of moving forward. I mean, at this point, we're pretty certain about how mandates are treated, even though we're uncertain about what plans actually, really look like. For 2014 and 2015, I've told you that I suspect that it will be the same in 2016. But really pushing for more robust or more infertility mandates in other states may not yield the results that you want. Remember that that January 1st, 2012 cutoff meant something. So if a mandate was not passed before that point, it is not considered essential health. It could not be considered essential health benefits, even if a state picks a benchmark benefit plan that covers it. So mandates that, you know, after the regulation went through, after it was finalized, that 2012 cutoff was already in place, and it was retroactive even at the point where they wrote the proposed rule. They didn't want states to go run out there, pass a bunch of mandates, and get them covered by essential health benefits. And it's probably a good thing because we're still so uncertain that where would the state be if we actually, you know, were able to do that. And so we don't know what that cutoff could be in future years. If CMS revisits this regulation, maybe allows states to pick a different benchmark benefit plan, maybe they'll write another cutoff for mandates, like that, you know, comes to 2014 or to 2013, but maybe they won't. And so the mandates that have maybe gone into place between 2012 and now, it's still unclear what could potentially happen to those in the future. So spending your efforts now pushing for more robust benefit mandates in those states either that don't have them, or, you know, strengthening those in those states that maybe have weak mandates, it may not be your best use of resources. It may be better, and we will talk about this absolutely later, you know, as patients or as advocates or as manufacturers, to really push for how to finally resolve the issue of mandates in essential health benefits, and to maybe reconsider the fact that states would be on the hook for this, or reconsider how to make states on the hook for this in a way that doesn't penalize states for wanting coverage in those states to be, you know, robust and thorough. Any questions on this at this point?
Yes, we have some questions. I just want to put a fine point on the map of the U.S. that you had up a couple of slides ago, where you listed 13 states that do not have an infertility mandate, but they list infertility treatments as part of their essential health benefits. And just to put a fine point on it, I've looked at Michigan. And if you go to the CMS website, it will have a chart of every state and what their essential health benefit covers. And it has a list of services, and it literally says yes or no. And if you look at infertility treatment under Michigan, it says yes. So you get real excited, and you think, oh my goodness, this is great news. They don't have a mandate, and now they're going to start covering infertility treatment. And then you pull up that actual plan document, which is some 50, 60 pages, and you look at what they have listed for infertility treatment, and it has one sentence, which is diagnosis, I believe, and then it lists all of the following is excluded. And it basically, for those of us in the infertility world, lists every possible thing that you would ever really need in terms of treatment or coverage. So you are absolutely right that the range of what is and isn't covered is so vast, and you have to dig through all of these plan documents to really understand it. So for those of you who are in one of those 13 states, we're going to have to really look and see exactly what does the plan document state. And I would attest that for the most part, it does not really add a whole lot in terms of actual coverage. We have quite a few questions, so hold on.
Our first question is, who decides which doctors are in network? Do doctors get to choose whether they are in the network or not?
That's a great question, and nothing changes with the ACA and with exchange plans. An issuer of a plan, creates its network the same way it always has, by offering to potential physicians and hospital groups and other healthcare providers a contract, and if the entity, the healthcare provider, wishes to enter into a contract with that issuer at the rate that they have established in the contract, then they can sign the contract and move forward. Nothing about that contracting process has been changed by the ACA. And I alluded to at the very beginning a little bit about network adequacy, and there's a lot of questions about whether networks are adequate in exchange plans, and there's probably going to remain questions about whether networks are adequate in exchange plans. But the state law dictates network adequacy and has essentially from the beginning of the health insurance market. So nothing the federal government did changes network adequacy requirements either. So how many providers or GPs or specialists of a specific type or hospitals a plan has to have to meet the needs of its enrollees, all of that is determined by the state. It's also overseen by the state. And if the state has a hands-off approach to oversight, which, as you might imagine, many states do, then it's probably up to self-attestation by the plan that the plan meets the state's network adequacy requirements. Whether that will last moving forward and whether the federal government will let hands-off states get away with that, particularly if folks are having trouble accessing their providers, even covered providers who are in network, all that remains to be seen. I think there could come a day that the federal government steps in and says this is not enough and that your network adequacy requirements are not enough, the same way they did with rate review, which is also a state-based service that states are required to review the rates established by a plan. And the rate means that sort of base premium that a person would pay. Those are reviewed by the state, and the federal government established a minimum level for rate review, and said if a state met this, then the states could absolutely continue to review rates. But if states didn't meet it, then the federal government would step in. And I think we could absolutely move to a place like that with network adequacy too, particularly with the media coverage of network adequacy of late, because it's not been good if you've been paying attention. That was probably too long an answer, but.
You might want to go back to that map for us for this next one. If you live in and are insured through one state that is orange and get treatment in one that is gray, will you be covered? Does that matter?
It doesn't matter. It matters what the plan is and what the plan covers, and if the doctor out of network or the provider out of network is, or the provider out of the state is in the plan's network. That is what matters.
Do you know when HHS will provide some guidance on the issue of the penalty that is currently waived?
That will probably come in the essential health benefit benchmark. And what we're talking to about the speaking about the penalty is that it's not so much a penalty; it's states being on the hook for mandated benefits that are in excess of essential health benefits. That on the hook payment, whatever that is, however it's defined, because it's pretty undefined at this point. The federal government has issued no guidance that we have found on that. So in Maryland, the fact that Maryland selected a benchmark benefit plan that does not cover, it doesn't meet the benefit, doesn't meet the mandate. So state plans are still on the hook. We said it's not the small group plans. The individual plans in Maryland are on the hook for covering that mandate, meeting the mandate, but the mandate is not covered by essential health benefits because the state selected a benchmark benefit plan that does not cover the mandate. And so how the state will make payments for those individual plans, for those services, and how that gets defined, and who makes the payment, and how does that work, and how does one determine what is above, what's in excess of essential health benefits and the value of that, none of that has been determined. As far as we know, Maryland doesn't know either. It's possible that the feds are not that interested in calculating this and may not collect on this, or may not force the state to pay the issuer or the person who was on, it's unclear. I'm fumbling only because we don't know. We don't know who pays what. We know that the state is on the hook for paying, but paying whom and how much and how that gets calculated is all unclear.
And I think you said earlier that you anticipate HHS possibly providing some guidance on the entire essential health benefit structure potentially later in 2014. And what you're stating, just to clarify, is that this on-the-hook payment issue, again, which has been waived for 2014 and 2015, perhaps will be bundled with that same guidance that may, we hope, come out later this year, correct?
That is right, and it's only waived because most states picked a benchmark benefit plan that met the mandate. In Maryland, for example, it's not waived. It remains to be seen how Maryland will pay.
Massachusetts has already introduced legislation to look at their mandates. Do you think other states will do the same thing?
I think it's possible. I think that there's a lot of concern about state budgets. There has been since, well, the beginning of time. States have to balance their budgets in a way that the federal government doesn't, and so states are always crunching numbers, probably way in excess of what the federal government does. And I think the fact that Massachusetts is interested in looking at its mandates, just shows that some people are very, very concerned about the fiscal outlook for their state. That said, we took a couple of glances at what's going on in Massachusetts, and one thing to note is that the 3 bills under consideration right now, they're not moving very fast. They were all introduced by Republicans. Massachusetts, at least, is a very blue state. And so not that that means that it's not going to go anywhere, but they're going to have to get the buy-in of a lot of Democrats in order to make legislation move in the state of Massachusetts. And so while that's not the case in other states, there are red states that could very well revisit their mandates as well. And I think it's a possibility that states will revisit their mandates, but nothing changes the fact that if the mandate was in place prior to 2012, then that mandate is considered essential health benefits if the state picked a benchmark benefit plan that includes the coverage. So even if a state like, Illinois changed its mind and they were like, we don't want to do this anymore. Now, I don't know anything about what the mandate is in Illinois. Let's imagine it's great. And Illinois was like, we don't want to do this anymore. And they changed it tomorrow. It's still a benchmark benefit. It's still considered a mandate for the purpose of essential health benefits because it was passed prior to January 1st, 2012. Sure. So the question is whether any of these states that have recognized mandates have begun the process of potentially restricting what's in their mandate. And I think Massachusetts is the only one I know of, and it's those 3 bills that are under consideration. And I think the likelihood of those moving forward, at least in Massachusetts on a fast basis, is very slow, or very low.
Okay, we have another question.
Great.
Speaking of Illinois, as a provider in St. Louis where 55% of IVF cycles come from patients in Illinois, will the ACA weaken the comprehensive Illinois mandate?
Can you repeat that question? I'm sorry. I just want to hear it one more time.
Sure. As a provider in St. Louis where 55% of IVF cycles come from patients in Illinois, will the ACA weaken the comprehensive Illinois mandate?
I don't think so. I think that plans in Illinois know that especially those on the border with Missouri, know that plenty of folks in Missouri are getting services in Illinois and plenty of folks in Illinois are getting services in Missouri. And so their networks, just like here in the D.C. area, where our networks absolutely cover D.C., Maryland, and Virginia because we are, such a metropolitan region with such a tiny little district here. It's the same sort of thing, that networks are broader. They go outside of the state. So even when a plan is based in Illinois or operating in Illinois or conversely Missouri, if the mandate in Illinois is there and the plan is in Illinois and the person is in Illinois, then the Illinois mandate absolutely applies to them. And I don't think that the ACA does anything that actually contradicts that or weakens it.
We have a point of clarification. To be clear, are you suggesting that infertility mandates currently in place will be recognized in 2015?
That is the case, yes. For 2014, 2015 will be exactly like 2014 for the purpose of mandates and specifically infertility treatment mandates. Any other questions? One more?
Okay, we'll do one more. Could HHS redefine essential health benefits more strictly in the future so that mandates are now essential health benefits? Sorry, I'm having trouble understanding what the question is. Could HHS redefine essential health benefits more strictly in the future so that mandates that are now essential health benefits are not in the future?
Absolutely, they could definitely do that. I don't know how willing they would be to do that. It introduces, if all mandates are cut out of the concept of essential health benefits, that probably doesn't make a lot of sense because one might imagine there's a lot of services that are required by mandate, things like breast cancer screening, things that are required by law now as well that are mandated in some states. And to arbitrarily decide that anything that's mandated is no longer essential health benefits is also quite strange. And so you'd have to like make some rules of what essential, I think you'd have to make a federal determination of what services fall into each of those 10 buckets in order to be able to do that in a clean way. And I don't know that there's a high likelihood that the federal government is going to decide what benefits constitute essential health benefits or not. I think that the federal government probably doesn't want to be in the business of creating a health insurance package, which is essentially what they would be doing. They'd also be on the hook for all of the angry phone calls about what's not covered and what is covered, and they probably don't want to be doing that either, and leaving it to the market that has been in place for a long time with the guidance of additional insurance market regulation that was introduced by the ACA is, I think, the likeliest way of going about it. And I think they could tweak a benchmark. They could figure out a different way to do it. They could potentially even establish a plan or two as a possible benchmark in some states, or create. I still think it has to be benchmarked to a plan that already exists. I don't think the federal government is going to start from scratch and say, if I were building a health insurance plan, this is what it would be. I don't think they want to do that. I don't think they're in the interest of have an interest in doing that. And I think it also opens up the possibility that when, and not to get too political here, but the White House was not always going to have a person in it that's as interested in health reform and health care as the current president. And so it could very well be, if the federal government is defining benefits and it swings the other way, then that benefit package is at risk of being drastically slimmed down or narrowed or changed in such a way that folks are not that excited about it. So really leaving it to states makes a lot of sense, or leaving it to some already established structure also makes sense.
And just a reminder, if your question was not answered in this section, we will be posting all the questions and answers on our website.
Great. And while I'm on this slide, I realized there was one key point that I wanted to make, and we took a look at premiums in those states with mandates, those orange states, and compared them to the states without the mandates, just to see on average. And we looked at, I believe, premiums for 50-year-olds, although we didn't write that down. That is what we looked at. Premiums are only 1% to 3% higher, depending on the state, in those states with mandates as opposed to without, or outside of the other states. And in those states with mandates, that 1% to 3% does not represent the cost of an infertility mandate, an infertility treatment mandate. Those states that have mandates are typically states that have other mandates compared to states that don't have mandates. And so those increases in premiums reflect just maybe a more hands-on approach to mandating benefits in some states versus others. So, the takeaway from that 1% to 3% is not that infertility mandates increase premiums by 1% to 3%. It's that states with mandates, including infertility treatment mandates, could raise the premium, but it's very little, maybe 1% to 3% on average. Great. Okay, so let's talk a little bit about what does coverage and cost look like in actual exchange plans, and how does a person shop for a plan? Because we've talked about what's required, we've talked about what the law said, we've talked about how that gets effectuated and through regulation and what it's supposed to be. But how does the person know? What do they look for? How do they figure it out? And one of the places they can figure this out, and one of the tools is healthcare.gov. That's the federally run portal for exchange plans, and that's the one that operates for the federally facilitated exchanges and those partnership exchanges, everything except for those state-based exchanges, those 16 states or 15 plus DC, which are operating their own. But we're going to first take a look at healthcare.gov. And as you see, there's not a lot of information here. This is essentially the snapshot of what you see about a single individual plan. You see a monthly premium, and that premium is based on you. It's based on your age. It's based on your tax credit if you qualify for assistance paying for the cost of your plan. So that premium reflects your own personal situation. It tells you the plan's deductible, the out-of-pocket maximum, and a little bit about co-payments and co-insurance, which are the costs that a person pays after they reach that deductible, but before they reach the out-of-pocket maximum. And then it gives you an opportunity to click to this document called the Summary of Benefits and the Provider Directory. And that's where you're going to get a little bit more detailed information, but still probably not enough information for a person to make a decision, let's just be honest. So the Summary of Benefits and Coverage is a standard formatted document that the federal government requires of every single plan that's out there. In fact, if you have health insurance, chances are good, well, chances are 100%, that that your plan was required to make one of these summaries of benefits and coverage for you. It looks the same. It's got the same sections. It says, here's the benefit, here's what it costs, and then the plan has an opportunity to describe a little bit more about what it means by something being covered or not covered or excluded. And looking here, the places to look on the summary of benefits and coverage, which is where you're going to likeliest find information about covered services that are covered infertility treatment services, is in this other covered services section or in the excluded services section. And if it is excluded, then it will be in the excluded services section. If it is in other covered services, this is all you'll see. A bullet point that says infertility treatment. That's it. That's what the summary of benefits and coverage says. There's not more details than that. It is seemingly covered by the Blue Choice Bronze TPO 005 plan. But what the it is, this has been the theme of the whole presentation, what the it is differs from plan to plan, potentially even in mandated states. So that is something to keep in mind as well, that this summary of benefits and coverage, though it gives you a little bit of insight into, like, is this path even worth going down? It does not give you the comprehensive list of what is covered by that plan. And so even in those states with the mandate, so say the mandate is comprehensive, plans are required to cover a comprehensive set of infertility treatments and services, they are also still permitted to define cost sharing however they would like, provide numerical limits on the number of treatments or services. They are also allowed to use formularies and place whatever drugs they want on whatever tier of whatever formulary and assign essentially whatever cost sharing as long as the plan meets the actuarial value of the metal level that the plan is in. And so if a plan has 4 tiers, most exchange plans have at least 4 tiers. 91% of exchange plans have at least 4 tiers on their formulary. Of that 91%, almost 20% have a 5-tier formulary. So we're looking at pretty differentiated formularies here in exchange plans. There is nothing that says that a plan must cover, preferred brand drugs. It doesn't say that infertility meds must be covered at the preferred level, or even at the non-preferred level, they could be covered at the specialty level. There's rules in the Medicare Part D program about what constitutes a specialty medication and how much it must cost in order to put that medication on the specialty tier. There's no such rule in exchanges. So if a plan decides to put potentially all of its infertility medications on the 5th tier, which could have cost sharing at 50% coinsurance, then they are permitted to do so. That doesn't necessarily constitute discrimination, particularly for plan year 2014. CMS has been fairly hands-off about what it means to have a discriminatory plan design, and they've said a little bit about how they're going to do outlier analyses, but then they didn't talk about what that means and how that's going to work. They did start to define it more for 2015, and it's possible that these kinds of things could rise to the surface for 2015, but for 2014, it's essentially a free-for-all at this point of where drugs are going to lie, how much cost sharing will be, and as long as the plan meets that actuarial value level, so for a silver plan, as long as the plan pays on average 70% of the cost of being in that plan for the average person, then it's fine. They could have cost sharing for infertility services at 80% if they wanted. There's no, if the state, in a state-based exchange, it's a little bit different. There are some states that are a lot more hands-on about what they allowed and what they didn't allow for plans. And it's possible it will look different in those states. But how much review the federal government is going to do about discrimination and discriminatory benefits, very minimal, particularly for this year, the current year that we're in. Go ahead, there's a question. Mm-hmm. That's right. So the question is about the number of drugs in every class and category that must be covered, and it must meet the benchmark. So if the benchmark covers 3 drugs in this class and 18 drugs in that class and 2 drugs in that class, then that's what the plans in that state have to cover, at least the same number of meds in each class and category. It's only if a plan, the benchmark, doesn't cover any drugs in a class, which sometimes happens on rare occasion, then the plans in that state must meet that one drug in that class. So it's like a fallback, that one drug per class. But again, when we talked about the UST classes and categories, the fact is that there's no class or category for infertility medications, and so there's no fallback one there because there's no category to capture it. Does that make sense? Yes. So the question is about generic alternatives of a brand that's not covered. For the purposes of the counting methodology and the requirement that the federal government makes about the number of drugs per class and category, that's all by unique chemical entity. So technically, the brand and the generic count as a single drug for that purpose. So even if the benchmark plan covers both the brand and the generic, that counts as one. And so a plan modeled after that benchmark only has to cover the one. So they could pick the brand or generic, and you answer what you would cover if you were in a health plan, the brand or the generic. Because nobody is looking to make sure they're covering brands too. Great. Again, doom and gloom. Last point on this slide is that many exchange plans use coinsurance for their highest drug tiers. So 70% of the plans that we reviewed use coinsurance for their highest drug tiers. And coinsurance, it's not that coinsurance in and of itself is a bad thing. It is it allows a plan to predict their costs better. It allows them to manage the benefit. A person knows that they are responsible for paying 25%, for example, of the cost of their medication. But they don't know what the cost of the medication is. They don't know the negotiated price between the plan and the manufacturer or the pharmacy benefit manager if the plan is not the one making that relationship happen. It's a very tricky thing for a person who is trying to compare plans, and if Plan A has a $50 copayment for this medication and Plan B has a 10% coinsurance, it's going to be really hard for them to compare what that means, apples to apples. And there's Google, and people can look these things up, and you can find a lot of pricing information on the web. But how accurate that is for the purpose of your specific plan and your specific medication and your specific pharmacy that you might go to, that is, it's essentially a rough estimate. Again with the doom and gloom. So coverage matters, tier placement matters. The other thing that also plans are allowed to do is utilization management. So that's prior authorization requirements, step therapy requirements, quantity limits, all of the same sort of utilization restrictions that are in place that maybe add barriers to an individual who is trying to access their medications in a plan. All of those sorts of utilization management techniques are permitted in exchange plans as well. And so, not to just throw plans under the bus here, because I think plans are in a tough situation, and they're bound by these actuarial value requirements, the tier levels, the metal levels that we talked about earlier. They're bound to keep premiums low to attract enough enrollment to make their networks, to make their profiles of their enrollees big enough and robust enough and attract enough enrollment. And really, they're under a lot of pressure by the federal government to keep premiums as low as possible and make sure that people enroll. I mean, people want young, healthy people to enroll in the exchange plans as much as they want folks who are, really in a lot more need of services to enroll in these exchange plans. They can't just cater to one side or the other, and they're bound by the ACA to offer plans to anyone who comes to the door. They can no longer turn folks away if they have a pre-existing condition. They can't charge them more if they have a pre-existing condition. So they want to bolster their ranks with folks who are young and healthy and vibrant and don't have any diagnosed conditions. The way to do that is to have premiums that are as affordable as possible. So to get good premiums, to get attractive benefit packages, and to do that, to do both of those things at the same time leaves very few levers for a plan to really meddle with. They know that they're required to provide preventive services at $0 cost sharing. They know they're required to have an out-of-pocket maximum. They know that they're not allowed to have dollar limits on any services anymore. So there's all these restrictions on plans, and so what they do is they mess with the things that they can mess with, and I mean that in the kindest of ways, and that it has to do with network adequacy and network breadth and depth. and access to specialists. All of these levers are places that they can, and really breadth of the formulary as well, these are levers that they can play with to help their premium dollars go further. And so we've seen a lot of narrow network plans and exchanges where the network of, I think, a particular plan in California is like a third of the providers that were in its previous individual market plan prior to the ACA. So the 2013 plan had something like 6,000 providers, and the ACA plan, the exchange plan, had 2,000. So it could very well substantially decrease people's choice in terms of who they pick, but also could increase wait times, not just in the waiting room, but like the wait time from when you call to the time you get an appointment. That time could absolutely be extended substantially based on these narrow networks. And we're hearing a lot in the media, especially in California, about super narrow networks, and the only providers who are accepting new patients are at essentially federally qualified health centers that are in the plan's network. The media reports have been very, very dramatic. And some might say, like, you don't really need access to a dozen super duper specialists for this, one very rare condition. Why should you need to pick from 12 people? Like, shouldn't one be enough that you have some rare condition or whatever? And maybe that's the case for super duper specialists, but maybe it's not the case for generalists and folks who, are they even checking to make sure that enough providers are in the network and taking new patients? Because that matters too. If you're in a new plan, you could very well be a new patient and need to get in the queue for that physician. And if your wait time is 8 months, which it could potentially be, it's a real problem. And I think network adequacy is going to be the hot topic for later this year and potentially into next year. And I think if states aren't doing something about it, then the feds will pretty soon. Specialists also in the narrow networks as well. It's hard to get access to a specialist. They also cost a lot. Copays are in excess of $40 for a specialist visit, and that's in over 70% of the silver plans that we analyzed had copays in excess of $40, which may not be a lot, except if you're going weekly, or that kind of cost adds up for folks. One thing to keep in mind is that even with these narrow networks, out-of-network benefits, again, don't count towards a person's out-of-pocket maximum. Some plans may have out-of-network benefits. Not all plans do. Again, read the fine print of plans in order to figure that out. But if most standard plans do not actually have an out-of-network benefit, and so if you're like, I don't want to wait for this narrow network provider, I'm going to go to this other specialist and just take my chances, the money that a person spends out of pocket at that out-of-network provider does not count towards that $6,350 out-of-pocket maximum. You want to pause for a second? Or should we move on? Two questions. Let's go.
Governments don't seem to love infertility coverage. It's often named as an outlier benefit. Could HHS come up with a list of mandates it will not pay for?
Absolutely, it could do that. There's, I don't think the federal government it has a big interest in deciding what is and isn't like a standard benefit versus an outlier benefit. I really suspect they're going to leave that to insurers and states. The federal government hasn't really stepped in the past in order to determine what benefits should be covered. Even in Medicaid, where it has the ability to do that, it hasn't really done that. It leaves all of that really up to states. There are certain categories that must be covered under Medicaid. I think in theory, yes, they could do that. Whether that is likely, I think is pretty low.
And do pre-existing conditions like infertility make your monthly premium more expensive?
They do not. That is a great question. No pre-existing condition can change your rate on anything anymore. If you have had 17 heart attacks over the last 17 years, your premium is the same. It's based on your age. So premiums can vary based on a couple of things: age, family size, geographic rating area, and I said that: age, family size, and geographic rating area. Those are the only three factors, if I'm remembering correctly. But absolutely, health status is not one of those factors. And so your premium is essentially based on the average population at that age. And so that's how it gets determined, not based on a person's individual situation anymore. So there's there shouldn't even be health screenings anymore for individual health plans, whereas you used to have to give a blood sample and, give your weight and your height and all that kind of stuff. All of that is gone. Great. So let's talk a little bit about what this means. We've talked a lot about what we know. We've talked a lot about what we don't know. We talked a little bit, we hinted a little bit about what comes next and potential timing and all of these things. First, let's talk about what consumers can do and what they should be thinking about. And so for a person shopping for an exchange plan, there's a lot to check. There's a lot of fine print to read. Healthcare.gov or a state-based exchange website may not have all the answers. The summary of benefits and coverage may have some more answers, but probably not everything a person needs to know. Potentially it's going to involve calling plans directly to find out specifically what specific benefits and what specific medications are covered by the plan. While the healthcare.gov and the state-based exchange, the summary of benefits and coverage will provide links to formularies so a person could look up drugs, potentially in those plan formularies. There's no drug finder tool the same way the Medicare Part D plan finder works. A person, except for in Nevada, cannot go to the website and enter their meds and have the plans be screened for what plans are covering their meds. Nevada is the only state that built that tool, at least for 2014. We could see that more in the future. But again, it's just drug side of things, not provider and not covered services kind of side of things. There could be access restrictions on numbers of visits. There will likely be utilization management and high tier placement and high cost sharing. It's very possible and very likely, in fact, that plans are going to want to restrict access to infertility treatments to the extent that they can. In those states with mandates, there's more protections in place for those mandated plans, but less in those, less in plans that do not have mandates applied to them, and even less in states that have no mandate. It is one of those sets of, it's a set of services, as you all know, that plans don't love to cover. They don't want to put themselves out there as covering it. It's just a set of services that it doesn't have the same feel for folks as, it's like helping little kids or whatever. People, it doesn't pull those same heartstrings for everybody. And I think a lot of plans are, want to just draw the line there, and that's what they do. And if they are given the opportunity to do that, then many plans have done that and will continue to do that. But consumers have the opportunity to really watch what's going on in the policy world and figure out what they know about the state mandates in their state, what the benchmark benefits plan looks like in their state. All of that is public information available on the CMS website, and I'm sure you can figure it out through Resolve's website as well. I'm sure there's plenty of resources there that help you figure out where to go to to learn about the mandate in your state, as well as what the benchmark plan looks like in your state. But in terms of shopping for specific coverage, those websites and summaries of benefits and coverage and probably phone calls are the best place to go to get detailed information. And then providers also have a role here in helping individuals figure out what plans might be best for them, particularly providers who are offering infertility treatments and services. It's really in their best interest to figure out what are the plans that are covering their services to, at the best rates and for the most opportune set of circumstances for individuals so that they can help people pick plans. And providers at this point are not, in the Part D world, in the Medicare Part D world, providers are really barred from doing a lot of steering into one plan versus another. But this could be considered provider education if a provider in the exchange plan world wanted to take the time to look at the plans available in their county or in their zip code or in their area or even in their state and figure out what plans covered fertility services to the most generous state. They are permitted to do that and to provide that information to individuals who are interested in getting that information. There's no reason not to. Providers should think about who they're networking or which plans they are in the network of. And we know that a lot of plans created their narrow networks on purpose. It's not like they went in there aiming to get a lot more providers and only so many providers signed up. It's that plans wanted to keep their provider network slim on purpose, and that is, that's the way they went into this. That said, providers can ask to be a part of a plan's network. They can review the contract and become a part of a plan's network. That's a two-way street. It's not just the plan offering the contract to the provider. Lots of times it works the opposite way as well, that the provider can come to the plan to participate in more plans if they would like to. There may also be a role for providers in helping individuals fulfill medical necessity requirements. It's possible that some plans will have criteria for medical necessity, that they will only provide coverage for certain services if some medical necessity criteria are met. If that is the case, then the provider could have a role in helping that individual prove that they have met the medical necessity requirements in order to get coverage for those services. This happens a great deal in infertility treatment and could very well continue. What the medical necessity criteria are per plan will differ by plan, and the provider can also help in figuring out what those criteria are per plan. Pharmaceutical manufacturers also have a role in helping to understand the situation, helping to understand what states have mandates, what those mandates look like, particularly those manufacturers that are not just with inline products but also with pipeline products. Should really understand how their medications are covered, should think about that in terms of their own contracting and strategies with plans, and think about how to get their products placed as favorably on formularies as possible, and helping consumers really access those products even if it is outside of the plan's benefit too. There are avenues for that as well. Again, manufacturers should consider formulary placement to the extent that they can and understand that high cost sharing absolutely is a barrier to access for many, many, many people. Again, we don't know what prescription assistance programs will look like, and I apologize that I don't know that if prescription assistance programs are something that happens in the infertility space. If it is, what we haven't seen is whether the OIG will allow coupon assistance programs in exchange plans moving forward. The OIG has not ruled on it. HHS has had conflicting guidance on it, and so at this point, there are some manufacturers that are moving forward with coupon programs and exchanges. Others are not, and I'm sorry that I don't know whether that exists in the infertility space or not. So that is, for other drugs at the very least, that is still a question mark. And then finally, what can advocates do? And I think that this is it's not so much a wait-and-see situation as you might think. I think there's ways to actively engage with the federal government about its future essential health benefits rule to really push for clarity on mandates moving forward and to push for a policy that's maybe a long-term policy and not this the start of another series of sort of short-term fixes for how mandates will fit into essential health benefits, and really think about what mandates look like in states moving forward. As we've talked about a lot, that the exchange marketplace, while it matters a great deal, it is not the end-all be-all. It is not all of enrolled individuals. Essential health benefits matters also a great deal, but again, it's not for all plans. I mean, there's a huge large group market, and a lot of times mandates apply to the large group market in states as well. And so it doesn't mean don't work for mandates. It doesn't mean don't push for more robust mandates even. And I think what it means is to think about how mandates fit into the context of essential health benefits and taper your expectations about where that will go, but also potentially push for mandates for large group plans or employer plans, state employee plans, or other places where mandates could matter a great deal for folks as well. Because the exchange population, while it matters for a lot of things, it's not it's not the hugest swath of the pie there. It's not the hugest piece of that pie. And while it matters for a lot of things like network adequacy and rates, and it could very well, coverage could begin to look more like what exchange plan coverage does look like, mandates are still operating against a bunch of other slices of that pie, or at least in conjunction with other slices of the pie. And so that's definitely something to consider. This is not a lost cause. This is not, well, let's, pat ourselves on the back and, go our separate ways and think that we're all done here. There's still plenty to do. And there's still, I think monitoring what happens in exchanges and pushing for better and more comprehensive coverage is a fine thing to do as well. So thank you.
Kelly, thank you. To that last point, and I think I may have shared this with you earlier, there was a mandate that was in the California legislature last year that would have mandated insurance coverage for fertility preservation. And that bill passed through the California State Legislature. And one of the concerns that we heard from state legislators is how will this be impacted by the implementation of the Affordable Care Act in 2014 and essential health benefits. So a wise member on one of the health committees said, how about if we draft this mandate and we make it apply to only those large group plans, meaning the fertility preservation mandate would be excluded in individual and small group plans. And I'm wondering if you're, with your experience, does that sound like a reasonable strategy in how perhaps mandates could be pursued in the future? Number one, giving all the uncertainty, but also then just taking away this whole issue that states are faced with. And by the way, while that bill then did pass, it was vetoed by the governor. So it's somewhat of a moot point, but we'd certainly love to see if that strategy is something that might work.
I think that's a great way to think about it, and it's unfortunate that the governor vetoed that in California. But if it's the sticking point is, what does this mean for the ACA and for individual and small group plans, and therefore it can't possibly pass, then restricting just to large group is a great alternative. It at least allows a mandate to move forward. It affects a whole heck of a lot of people, and it matters a great deal to those folks that it affects. And if by restricting it just to the large group, it allows that legislation to move forward because of the uncertainty about how mandates will be fit into EHB in the coming years, then I think go for it. I think that's a great approach, definitely.
We have one question. What about pre-certifications on infertility for an Illinois state mandate policy? And all other Illinois state mandate policies do not require.
Well, I don't know exactly about Illinois state mandate policies, but pre-certification is another one of those utilization management techniques that plans use in order to essentially restrict access, in order to add barriers, in order to manage the benefit for folks that are enrolled in the plan. It gives them a way to make sure that the person really qualifies for the benefit and that they're not just talking some rogue doctor into providing some benefit for them. It gives them a chance to look at medical necessity criteria or whatever it is that the rule that the plan makes that the person has to meet in order to qualify for the coverage of the benefit. And so pre-certification is the same sort of thing, like step therapy or quantity limits or other things that you see on formularies. It's a very similar process, and it is permitted.
Okay, that is all the questions that we had coming in online, but I want everyone online to remain logged in. We just have a few more slides and a short presentation from Resolve's President and CEO, Barb Clora. So please hold on.
Thank you. I want to thank Kelly Brantley of Avalere Health. That was an excellent presentation, and you conveyed a lot of information. We so appreciate your time. I again want to thank Merck for providing a grant for us to be able to work with Avalere and provide all that information. I want to just share with you a few slides from Resolve, and let me go ahead and get started. For those of you who aren't as familiar with Resolve, we are Resolve, the National Infertility Association. We're a nonprofit organization founded in 1974, and really what we do is improve the lives of people diagnosed with infertility. So we talk a lot in our world about community, about looking at infertility as a cause, and really connecting people with infertility to that whole community. We want to empower everyone who is living with or diagnosed with infertility to find their resolution. And a key part of our mission is to give voice to the infertility community. That's all of us, whether that be in a public policy sphere or just in the public awareness sphere, just giving voice to all of us. So again, Resolve is a charitable nonprofit organization. We're headquartered here in the Washington, D.C. area in McLean, Virginia. And a lot of people ask us where our funding comes from. It comes from individuals. We get a lot of individual donations, professional memberships, corporate philanthropy, and sponsorships. Sponsorships comes in a lot of different ways through our events and our other programs and services. A key part of our mission is in the public policy sphere, and we really bring the entire infertility community together to ensure that their voices are heard. So we do that through federal and state legislative initiatives, and really it involves any type of policy, legislation, or what have you that impacts access to any family building option. So that may include IVF, gestational carrier surrogacy, donor egg, adoption, a number of ways, really all of the ways that impact family building options. When we look at a bill in a state or at the federal government and decide whether Resolve is going to get involved, because we do have very, very limited resources, we ask ourselves a couple of questions. Does this bill in any way impact people's access to a family building option, either by increasing that access or by restricting that access? And then number two, we look at the sphere of all the other organizations and others who may be interested in that particular issue and decide if Resolve's voice is needed, is important, because on some issues, to be quite honest, there are hundreds of voices. And on some issues, it's Resolve, it's ASRM, and that's about it. And in those cases, we recognize how important it is for us to be there and to show up. So again, our job is to speak and to be the voice, but we also are very, very involved in working to reduce the financial burden for family building. Again, all of those different ways that you build your family, but reducing that financial burden. One of the things you will never, ever, ever hear Resolve say is that something is expensive. Truth be told, it's expensive to break your arm and get sent to the emergency room. It's expensive to have back surgery. It's expensive to have heart surgery. But most people aren't paying out of pocket for those. And so when you are faced with paying out of pocket for something, I don't care if it's $500 or if it's $50,000, there are going to be people who are going to say, that is very expensive. So for us, that's a very subjective term, and we do not believe that family building is expensive, but we believe that there are ways to reduce the financial burden and the out-of-pocket costs for people. A shameless endorsement and plug here for a lot of activity that Resolve does. National Infertility Awareness Week. This is the only federally recognized health observance for infertility. We are celebrating its 25th anniversary this year in April, and it's a very, very important milestone for the entire infertility community and an opportunity to raise public awareness. If you do not have these dates already imprinted on your calendar, please do so, because this is a huge opportunity for the community to come together, again, thinking about 25 years of raising public awareness about the disease of infertility. You have an opportunity to come to Washington, D.C. and see many of us in the room who will be at our Federal Advocacy Day on May 7th. We'll be meeting with senators and representatives, and we'll be sharing with them concerns about that the infertility community has. We'll be advocating for specific bills, but mostly we'll be educating them about the infertility burden, the infertility issues of the infertility community. This is professionals, this is providers, this is insurance companies, this is pharmaceuticals, and yes, this is patients and their families. All will be represented and all are welcome. It is actually a free event, and Resolve hosts this for our entire community. We have Walks of Hope in several cities. We already had one last weekend in Houston. We had over 800 people register for a Walk of Hope in Houston. These are huge events. They raise public awareness and they raise funds. In 2013 alone, the Walks of Hope raised over $300,000 for Resolve. And lastly, our Night of Hope. This is our annual gala in New York City. We give out the Hope Awards, and it's a celebration of the accomplishments of this community. So I want to share with you, in picking up on the presentation from Kelly Brantley, those states that have some comprehensive IVF mandates. If you think about the mandates, there are 15 states in the United States that have a mandate. Okay, but what does that really mean? Some of them are a mandate to offer, and when the rubber hits the road, they are meaningless. They almost do nothing for improving access to people's care. There are 8 states out of those 15 that have a a mandate that actually requires coverage of IVF. Out of those 8, 2 of them, Arkansas and Hawaii, are quite weak. They have either very, very long waiting periods. Hawaii, for example, is 5 years, or the benefit itself is very, very minimal, specifically for IVF. So to be honest, there are 6 states that have a pretty decent IVF mandate. Some of those are not as great. The Maryland one, for example, has a 2-year waiting period and has some other restrictions. Some have age restrictions. They are, for the most part, 6 very different plans in six states. But those are the states that, again, have what we believe to be a fairly decent IVF mandate. So I'm going to focus on Maryland and Massachusetts because right now we do have some activity because the providers and the patient community in Maryland and Massachusetts have been concerned about what Kelly has shared, have been concerned about what happened in 2016. Because as Kelly has explained, the essential health benefits and the states choosing these benchmark plans was only supposed to be for 2014 and 2015. I personally sat at a hearing in Maryland where one of the Maryland state employees was advising one of the commissions looking at how they set up their exchange, and she kept saying, may I remind the committee, this is only for 2 years. You are not making decisions that are going to last forever. So that 2-year window has been what's been concerning all of us in terms of what happens in 2016. We've heard over and over in Kelly's presentation that they anticipate HHS coming out with some guidance on what is going to happen in 2016. And as Kelly has said, it's hard to fathom that it's going to be a whole lot different. And they may buy themselves another year just to gather themselves more data. But the folks in Maryland and Massachusetts are still believing there's an opportunity, even in the absence of those guidelines right now. So in Maryland, Shady Grove Fertility has decided to do something called a legislator thank you campaign. And they're going to roll this out in 2014. One of the things that we have learned is that we've become very complacent about these IVF mandates. We have not used opportunities to thank the state legislators. And in states like Maryland and Massachusetts, where the mandates have been around for many, many, many years, there's a whole host of state legislators who weren't around when these were passed. In fact, they may not even know their state has an IVF mandate, nor has the infertility community been thanking them and reminding them and telling them how important that mandate has been to their state. So guess what? We want to change that. So in Maryland, we want to thank the state legislators. We want to let them all know how many babies have been born, how many families have been created, how impactful this Maryland IVF mandate has been for the state of Maryland. So that includes outreach to legislators, but through a network of in this case, Shady Grove Fertility, they're going to use their resources to activate patients, look at their patient database, patients from 10, 15, 20 years ago. Using social media, how can we blanket Annapolis, which is the state capital of Maryland, with thank you letters? How can we let every single state legislator know how important this mandate has been? We'd also love to see some positive media stories, maybe even some op-eds, some real-life stories of how the mandate has impacted people. Now, this is not about changing policy. This is not about advocating for a bill. This is laying the groundwork. This is making sure that every state legislator knows that they have constituents who care about this mandate. In Massachusetts, they've ratcheted up the activity level a bit more, and they're actually looking at forming a coalition. And Resolve of New England has been very instrumental in this effort. And this is, again, in preparation for what HHS may come out with about what happens with those essential health benefits. So this coalition in Massachusetts is actually very, very inclusive. It's really any stakeholder in the state of Massachusetts who cares about this. So far we've had providers, we've had clinics, specialty pharmacies, the pharmaceutical manufacturers, and others actually who've come forward and said, we want to be a part of this. We care about this mandate in Massachusetts. We don't want anything to happen to it. So they are looking at a lot of different initiatives. This coalition is. In fact, they'll be having a meeting as quickly as next week. And some of these decisions may be made, some may be made at a future time, but they're even considering, should they be hiring lobbyists? Should they be looking at some PR firms and providing some targeted outreach, looking at a similar kind of thank you campaign, maybe even an advocacy day in Massachusetts that brings people to the state capitol where they meet with their legislators and personally say thank you. Lots of different ideas, possibilities. Again, this is what's already happening in Massachusetts. From Resolve's perspective, somebody posed a question about a comment that Kelly had made earlier about how states and insurers look at infertility treatments. And I think she used the example of, gee, it's tough to turn away, an issue regarding kids. Well, you know what? We really believe at Resolve that infertility is a disease. We believe it should be absolutely covered by health insurance. We would love that we wouldn't need state mandates to make that happen. Wouldn't it be great if it just was covered? That's our dream. That's our goal. And so what we want to try and do throughout this process, but then is everything from our Walks of Hope to National Infertility Awareness Week, it's about changing public perception about the disease of infertility. So there's a lot of work that needs to be done. But in terms of Resolve's activity as it relates to the ACA, we have web content. We told you this webinar is going to be posted. Tomorrow we're launching a frequently asked questions document that has been, it's a list of very specific questions regarding infertility coverage and care that Avalier answered for us. And Ferring Pharmaceuticals provided a grant to us to be able to create and post that FAQ. We're also going to be designing patient-friendly content. Today's presentation was for professionals. This was not broadcast to the patient community. You can imagine the detailed slides that were given today would have been really difficult for a lot of patients and maybe even scared them. So our goal is to provide and create patient-friendly content as well, so that patients know exactly what's going on. We'll continue to monitor and analyze these HHS bulletins and rules and continue to consult with Avalier and others on what it means and what we possibly can do. This isn't something that you're going to call your senator or your congressman and ask them for help on. The ACA is done in Congress. So this isn't something we're going to be lobbying for Congress on, but what can we be doing and influencing in our states and perhaps even at HHS. But I don't want everybody thinking I'll call up my senator and tell him because that's really not going to be the way that this is solved. We're going to be obviously supporting any state activity. Again, I mentioned Maryland and Massachusetts. As needed, we'll be activating our nationwide network. We have thousands and thousands of people in our database all over the state, and then providing, as we can, leadership guidance and expertise on this issue. So, we want to hear from you. What do you think needs to be done? What have you heard today? How does this, sit with you? Do you see opportunities for all of us to come together? This is something that is, yes, important for those states that have mandates, but this is one of those situations like in Massachusetts where everyone's going to have to come together to really make an impact, and so that's what we are looking at. If everyone is going to sit back and let Resolve do this or let ASRM do this, I can assure you it will fail because we have to have everyone working together, and that's just why coalitions work and why they are so successful, whether they're at the state or the federal level. So I would love to hear from you. I would love to have your input on this. If you are in a state with a mandate, for example, if you're in Illinois listening to this and you want to get involved, we can connect people in Illinois together. We can hold conference calls. We can discuss ideas and help you move forward with plans or strategies. Folks can see what happens in Massachusetts and Maryland, and maybe those are replicated in other states as well. And I'm just going to leave this last slide up for contact information so you have the ability to reach us. The easiest way is always to email info@resolve.org, but we have all of our email addresses up there as well. And I'm going to ask Rebecca if there's any questions or comments that have come through.
There are no additional questions right now.
Okay. We do have here in our Washington office, or not Washington office, in our location right here in Washington, we have the Chief Policy Officer for the ASRM, Sean Tipton, with us. And I'm going to totally put him on the spot here and see if Sean, if there was anything, actually, could you come up and make a few comments? Again, this is Sean Tipton. He heads the Washington office for the ASRM, and the Washington office handles public policy and other media outreach issues.
Thanks, Barb. I know this was primarily targeted to the provider community, and we certainly support Resolve all the time. Three of our four staff members in Washington are here in the room right at the moment. We did send out notices about this event. I don't want to step on it because it is a Resolve event. What I would say is I'm pretty sure in saying that if anybody that does not have an ASRM email address, Barb Kluwer gets more emails from me than anybody else. So we work very closely with Resolve, and we will certainly continue to do that. I would say if any ASRM members or providers have any questions specifically about our activities, I would just invite you to email me rather than take the time here, and that's stipton@asrm-dc.org.
Great. Thank you very much. Are there any questions from anybody in the room? Yes. So the question is regarding the coalition in Massachusetts, and if that's a strategy that will be replicated, what was Resolve's involvement, and how did that get started? The Massachusetts mandate is very, very comprehensive, and it has been in place for a long time. So the community in Massachusetts has always been incredibly involved and supportive of its IVF mandate. So when there was starting to get concerns about what happens in 2016, there were beginnings of some conversations amongst some clinics and really some manufacturers who were concerned about this. So they started meeting and having some conversations informally and then more formally. And Resolve New England, which is a standalone organization that operates in Massachusetts, they have helped facilitate some of these initial meetings and discussions and have been kind of a convener, if you will, as well as a couple of clinics that have been very involved. Now, really, it's the whole spectrum in Massachusetts. So they're just getting started in terms of what their activity level will be and so forth. They're still working on that and their structure. So I think it's a little bit early to necessarily replicate it because they're still forming it. But in terms of our role, Resolve's role in other states where there isn't any other entity like that, we would need to look at what the community in that state was interested in doing, what we could do, what ASRM could do, and look at it that way. It may be that we have a cookie-cutter formula that works across states. It may be that each state operates a little bit differently. I'm thinking that we're going to probably spend our resources on those 6 states that have those mandates. Arkansas and Hawaii, I'm not forgetting about you. So we could stretch it to the 8, but there really is no need, in my opinion, for 50 states because this doesn't impact all the other states. I mean, it really, really impacts right now 42 or it excludes 42 or 44 states, depending on how you want to look at it. Now, to the point of new mandates, like we talked about the fertility preservation one in California, that bill was actually led by the ASRM. And so that fertility preservation bill in California had widespread support amongst a number of organizations, but it was a very well-drafted bill, and it got very, very far. Obviously, it got to the governor's desk. So in states that are looking at improving their mandate or adding a mandate, whether it be for IVF or fertility preservation, what you've heard today from Kelly is don't abandon those, proceed cautiously, and that, again, needs to be wide coalitions that work on those kinds of efforts. Another question. So the question has to do with a bill that's in Congress that's called the Family Act. And the Family Act has been introduced in the House and the Senate. It will be a bill that we are advocating for on May 7th at our Advocacy Day. And the Family Act is very, very different. It creates a tax credit for your out-of-pocket costs for IVF and fertility preservation. It's modeled after the existing adoption tax credit and has income caps. It has lifetime benefit caps. Because it's not an insurance plan, it's not an insurance benefit. It's a tax credit. It has absolutely nothing to do with the ACA and vice versa. So could they coexist? Absolutely. So technically, I guess everyone in the United States could have insurance coverage for IVF, and there could be a tax credit. So they could coexist. What we have tried to tell people and tell legislators is that right now, so many people don't have insurance coverage for IVF. And the Affordable Care Act did nothing really to add infertility as a covered benefit. So really, until our dream of full coverage exists, can we at least have the Family Act and have that help what we believe is a lot of people? It's a great question. And we have another question?
Someone would like to know whether there could be state legislation we should be writing in Massachusetts or other mandated states to protect the infertility mandate, and if so, what could such legislation look like?
It's a great question, and I think we would need to convene some experts, because one of the things that actually doesn't exist is a model infertility mandate document. So everyone can say, you know, this state has a great IVF mandate, or this state does, but there really isn't that piece of model legislation that has been created. And if it was created many, many years ago and probably would need some updating. So in light of what the ACA has done, especially with essential health benefits, with these individual and small group plans, it would behoove us as a community to put the resources into drafting what a good IVF mandate would look like today, under today's environment. You know, I asked Kelly that question about the California fertility preservation mandate, and that at the end it had this exclusion, right, for the individual and small group plans. And that might be something that an expert tells us is a good strategy. So I think that might be a worthwhile exercise for our community. Well, I want to again thank Avalere Health. I would love to thank the folks from BIO who have provided this facility for us, and I want to thank Merck for providing this grant and the vision of working with us on this. I want to say that we have received so many questions over the last year or so regarding the ACA, and it really has picked up in the last few months. And so this was an effort to respond to all of you and all of the questions we were getting, and to provide what I thought was needed, which was everybody get grounded in the basic information, and then specifically what it means for the infertility community. And then I think we're in a position to make some informed decisions about how to move forward. So I really hope that has been accomplished today. I hope that you feel that this has been worthwhile. And again, we would love to stay in touch with you and reach out to us. Sean Tipton has also given you his email address at ASRM. But thank you very much, and we will be sending you a link to this webinar in the next few days. Have a great day.